Today we're tackling a topic that is really at the core of emergency medicine and cardiology, antiarrhythmic drugs.
Right. We're taking a deep dive into the very engine of life, the heart. And specifically, we are exploring the pharmacological tools designed to fix what happens when the heart's perfect, synchronized electrical timing goes completely haywire.
It's a fascinating but definitely a high-stakes topic.
Right.
We are essentially talking about the drugs that fix the heart's electrical short circuits. When the rhythm of the heart is off, its ability to pump blood efficiently is compromised, and the risk to the patient escalates almost instantly.
Okay, let's unpack that right away. Our source material details this incredible complexity of the cardiac electrical system and how a foundational framework, the modified Vaughan Williams classification guides, treatment choices. But before we get to the fixes, we have to grasp the magnitude of the problem we're trying to solve. What is the fundamental risk we are seeking to mitigate with these powerful medications?
The gravity is immediate, and it's stark. Arrhythmias are, unfortunately, the single most important cause of sudden cardiac death, period.
The single most important cause.
Yes. And when we look at the clinical statistics, particularly for patients who are dealing with acute coronary events, the numbers are pretty sobering. Nearly 3 out of 4 patients who experience an acute myocardial infarction, a heart attack, will exhibit some type of electrical irregularity in the immediate aftermath.
Wait, hold on. That's a staggering rate. If 75% of heart attack patients show an electrical glitch, are we giving these powerful, complex drugs to 3/4 of people recovering from an MI? That seems like a massive intervention.
That's a critically important question, and the answer is a firm no. Our source material makes it very, very clear that restraint is key here. We only intervene pharmacologically when the arrhythmias are serious, which means they're life-threatening, or when they are symptomatic, meaning they severely impact the patient's quality of life. Things like palpitations, dizziness, fainting.
Wait, not every little blip on the monitor gets a drug.
Not at all. Many of these irregularities are transient or minor and might be best left alone. The risk of the drug can sometimes outweigh the risk of the arrhythmia itself.
So we are targeting the dangerous minority. Our mission for this deep dive, then, is to trace the precise mechanisms of those truly dangerous electrical failures, and then understand how this complex 4-class roadmap, class 1, 2, 3, and 4, selectively targets the specific ion channels or receptors that are responsible for the chaos.
Exactly. We're essentially charting the architecture of the heart's electrical repairs.
To truly appreciate the chemical solutions, we first need to understand the electrical failures. The heart's rhythm depends on these flawless, synchronized action potentials. When that rhythm fails, our sources point to 2 main genesis mechanisms: abnormal automaticity, and then the devastating electrical short circuit known as re-entry. Let's start with the first one.
Right. The first failure mode is abnormal automaticity. It's also known as enhanced ectopic pacemaker activity.
That's a mouthful. Break it down.
Okay, so normally only specialized tissues,
Right.
primarily your sinoatrial node, the SA node, possess the ability to spontaneously depolarize. That's automaticity. It's the natural pacemaker. But under pathological conditions like ischemia after a heart attack, this fundamental rule breaks down completely.
And what causes that breakdown? Why do other cells suddenly decide to become pacemakers?
It's all about cellular injury. When myocardial cells are injured or become partially depolarized, say, from what's called an injury current, immediately post-MI where ions are leaking across membranes, they lose their stable resting potential.
They're not fully resetting.
Exactly, and because they are stuck in this partially depolarized state, they become vulnerable to spontaneously generating or initiating impulses on their own, completely outside of the SA node's control. They start acting as ectopic pacemakers.
Ectopic just meaning in the wrong place.
In the wrong place at the wrong time. It's like having rogue musicians in an orchestra who just decide to start playing their own rhythm, leading to total cacophony.
That's a perfect analogy. And
Okay.
it doesn't stop there, right? Our sources also talk about something called after depolarizations.
Precisely. And these are even more insidious. They aren't spontaneous new impulses from an ectopic cell, but rather hiccups. They're secondary oscillations that piggyback on a normal or even a premature beat. They're subtle, but they are incredibly potent triggers for sustained, dangerous arrhythmias.
These sound incredibly tricky. We have 2 types listed, early and delayed. Lay out the distinction for us, because I think understanding the timing of these 2 is key to understanding drug toxicity later on.
It is absolutely key. Let's start with the early after depolarization, or EAD. The crucial word here is early. This oscillation happens when the cell is trying to reset itself during the repolarization process.
So during the recharge phase.
Yes, specifically, it often interrupts phase 2, which is the plateau phase of the action potential, or it slows down phase 3. The cell basically fails to properly repolarize.
And why does this failure happen? What's the molecular reason?
EADs are strongly associated with slow repolarization. On an ECG, this shows up as a prolonged QT interval. This often happens when there's a suppression of the delayed rectifier potassium currents.
Okay, in simple terms.
The potassium ions, which are supposed to rush out of the cell to reset it, can't leave fast enough. If the cell stays depolarized for longer, it gives certain calcium and sodium channels time to reactivate slightly, causing the membrane potential to dip and oscillate upwards. If one of those little oscillations is big enough to reach the threshold,
We get another beat, an extra unwanted impulse.
you get an arrhythmia. So an EAD is fundamentally a failure of the reset function, leaving the cell stuck in a vulnerable, partly charged state.
Okay, that's clear. Now contrast that with the delayed after depolarization, or DAD.
Right. The critical word here obviously is delayed. This depolarization occurs after the cell has completely repolarized
Yeah.
and has already reached its stable resting membrane potential.
So the reset is complete. What could possibly destabilize it again?
The culprit with DDs is almost always high intracellular calcium levels, a calcium overload.
And where does that come from?
It happens in conditions like ischemia, reperfusion injury, that's when blood flow returns to damaged tissue, or even digitalis toxicity. When the cell is just flooded with calcium, it tries to get rid of it. The excess calcium is rapidly extruded, often through an exchange mechanism that involves the sodium channel. This abnormal influx of positive current generates that secondary depolarization, pushing the membrane potential back up towards the threshold.
And if it hits threshold?
It fires off extra beats. These are often called triggered arrhythmias.
That makes the distinction really clear. EAD is a potassium efflux failure during repolarization, and it's linked to a long QT. DAD is a calcium overload event after repolarization. This incredible molecular detail is what guides the choice of drug, which is just astonishing.
It really is.
Now we move to the mechanism that our sources say causes the vast majority of sustained, serious rhythm disturbances. The short circuit, or reentry phenomenon. This sounds like the electrical traffic jam that never resolves.
It's the definition of a rogue signal. Imagine a normal electrical impulse traveling down a path. It should activate all the tissue once, and then it should stop. It should die out. In reentry, that impulse gets caught in a continuous circus movement.
A circus movement.
It finds a path that allows it to loop back and immediately re-excite the tissue it just left, starting the whole cycle over and over again indefinitely.
Okay, what are the two non-negotiable requirements for this continuous electrical loop to get started and sustain itself?
Two things must happen, and they are synergistic. First, there must be a unidirectional block.
One-way street.
Exactly. Imagine the impulse splits and tries to travel down two parallel paths, path A and path B. Let's say path A is refractory. It was just active, and it can't transmit the impulse. But path B is ready. So the impulse only goes down path B. That's your one-way block.
And the second requirement.
Second, and this is the really critical part, there must be slow conduction velocity in path B. The impulse has to travel slowly down that open path.
Why is slow conduction so crucial? Why does the speed matter?
The slow travel down path B provides the necessary time delay. It's all about timing. By the time that slow-moving impulse reaches the end of path B, the tissue in path A, the one that was initially blocked and refractory, has had enough time to recover its excitability.
Ah, so it's ready to be activated again.
It's ready again.
Yep.
So the impulse now travels backward up path A, and when it returns to the starting point, path B has also had time to recover. The circuit is now self-perpetuating, and the heart is locked into a rapid, sustained tachycardia.
So the impulse delays long enough in one lane for the other lane to reopen behind it. It's a perfect storm.
Our sources clarify this can happen through anatomical reentry involving a fixed obstacle like scar tissue or the AV node pathway, or functional reentry.
And that functional kind is particularly chaotic and dangerous. The circuit is purely physiological. It's defined by localized differences in refractoriness, and it can shift from minute to minute. This is what's responsible for the highly irregular, fast rhythms like atrial fibrillation and ventricular fibrillation. Reentry really does account for virtually every major clinical arrhythmia we treat with these drugs.
Okay, so with those mechanisms in mind, let's quickly define the primary clinical problems our drugs are designed to solve, starting with the most lethal one, ventricular fibrillation, or VF.
VF is an absolute clinical emergency. It is characterized by irregular, rapid, and fractionated electrical activation of the ventricles. Crucially, the activation is so chaotic that the ventricles cannot contract synchronously, they just sort of quiver.
So there's no coordinated pumping action at all. None. The cardiac output immediately drops to zero.
And without intervention.
It is rapidly fatal. Unless the rhythm is electrically reverted, usually by defibrillation within 2 to 5 minutes, the outcome is death. It is the single most common cause of sudden cardiac death. If the goal is not to die, VF is what we fight against the hardest.
Next, the unique rhythm that's associated with vulnerability and that QT prolongation we mentioned. Torsades de pointe, TDP.
Right. Torsade de pointe, which is French for twisting of points, is a really descriptive term for a life-threatening polymorphic ventricular tachycardia. When you look at the ECG, the QRS amplitude appears to cyclically wax and wane around the baseline. It looks like it's twisting.
And this is linked to the EADs we talked about.
Intimately. It is always associated with a long QT interval, the marker of delayed repolarization, and therefore the presence of those early after depolarizations. This rhythm is often triggered by things like low potassium or low magnesium, or, ironically, Class IA and Class III antiarrhythmic drugs.
And there's the paradox right there. A drug meant to prevent an arrhythmia can create this particularly nasty one.
Exactly. Now, on the chronic, though less immediately fatal side of things, we have atrial fibrillation, or AF. Our sources note this is the most common chronic arrhythmia overall.
So what's happening in AF?
AF is total chaos, but contained to the upper chambers, the atria. The atrial fibers activate asynchronously, meaning they're firing off impulses at an extremely rapid, disorganized rate. We're talking 350 to 550 beats per minute.
And the AV node, the gatekeeper between the atria and ventricles, gets hit with this bombardment.
It does. And the AV node can only transmit a fraction of those impulses, but the resulting ventricular response is still rapid, maybe 100 to 160 beats per minute, and crucially, it's irregularly irregular. The beat is completely unpredictable.
What's the resulting problem for the patient?
Well, the inefficient pumping leads to fatigue and shortness of breath. But more dangerously, the irregular atrial activation causes blood to pool and become static in the atria, which massively increases the risk of stroke due to clot formation.
Finally, let's touch on the sudden, usually self-limiting but very symptomatic bursts. Paroxysmal supraventricular tachycardia, PSVT.
PSVT is characterized by sudden, brief episodes of atrial tachycardia, often between 150 to 200 beats per minute. These are typically caused by a rapid reentry circuit located in or very near the AV node.
So this is that reentry mechanism again.
It is, and while it's usually not immediately fatal, the acute onset causes really distressing symptoms for the patient, like intense palpitations and dizziness. So acute termination is a clinical priority.
Okay, we've established the chaos, spontaneous firing, secondary hiccups, and continuous loops. The drugs we use to restore order are universally organized by the Vaughan-Williams classification system.
It's the organizational key to this entire field, really.
So what's the unifying basic principle behind how all these different drugs function?
At their core, all antiarrhythmic drugs work by deliberately altering the electrophysiological properties of cardiac cells. They achieve this by either blocking or modulating one of 4 major targets: the primary ion channels, so that's sodium, potassium, and calcium channels, or the autonomic receptors, mainly the beta-adrenergic receptors.
It's chemical engineering applied to electricity.
That's a perfect way to put it.
So we have this highly specialized toolkit where each class targets a different point in the cardiac action potential. Give us the high-level roadmap of the 4 classes.
Okay, Class I drugs are the membrane-stabilizing agents. These are the classic channel blockers. Their primary target is the fast sodium channel, which is responsible for phase 0 depolarization, that rapid upstroke of the action potential.
So they slow things down.
They slow down the speed of that initial depolarization and slow conduction velocity. They also reduce the spontaneous firing rate in those ectopic cells. It's a large, complex group, so it's subdivided into IA, IB, and IC based on the intensity and duration of their effect.
So Class 1 is about slowing the speed of the electricity itself. How does Class 2 differ?
Class 2 drugs are the anti-adrenergic agents, which you probably know as beta blockers. They don't work directly on the ion channels in the same fundamental way. Instead, their mechanism is more systemic.
How so?
They suppress enhanced automaticity, especially the kind that is driven by high levels of catecholamines, your stress hormones, adrenaline. They essentially calm the heart by slowing down the SA node and prolonging conduction through the AV node.
In Class 3, the ones that target that reset phase, repolarization.
Class 3 agents are the action potential widening drugs. They achieve this by blocking potassium channels. As we said, potassium channels are responsible for the cell resetting itself. By blocking potassium from leaving the cell, they significantly lengthen the action potential duration, the APD, and crucially, the effective refractory period, or ERP.
And if you make the tissue refractory for a longer period of time, you prevent the impulse from being able to loop back in a reentry circuit.
Exactly. You give the tissue more time to recover completely, which can shut down that continuous circus movement. It breaks the loop.
Finally, class 4, which you mentioned, act as the gatekeeper.
Right. Class 4 drugs are the calcium channel blockers, specifically the non-dihydropyridine types like verapamil and diltiazem. They block the slow inward calcium current.
And why is that important?
Because the SA and AV nodes rely heavily on these calcium currents for their function. So these drugs powerfully depress the automaticity of the SA node and dramatically slow conduction through the AV node. They are the essential brakes on the system.
That gives us our blueprint. Sodium class 1, beta blockers class 2, potassium class 3, and calcium class 4. Let's start drilling down into the specific agents, beginning with the complex and sometimes dangerous world of the sodium channel blockers.
Let's do it.
We begin with class 1, the sodium channel blockers. The core operational principle here is really elegant, and it defines their clinical utility. Use-dependent block. Can you explain why this concept makes them so effective at targeting diseased tissue over healthy tissue?
This concept is absolutely essential to understanding these drugs. Most class I drugs bind preferentially to sodium channels that are either in the activated state, that's during the phase 0 depolarization, or the inactivated state, which is during the plateau phase. They bind very poorly to channels that are fully rested and recovered.
So what does that mean practically for a patient with a fast heart rate?
It means the drug is much more effective, the block is much stronger, in fibers that are firing rapidly or in use, like in a pathological tachycardia.
Ah, I see.
If a cell is beating 300 times a minute in a reentry circuit, the drug gets 300 chances every minute to bind to that open or inactivated channel. If a cell is beating normally at 60 times a minute, the block is far less pronounced.
So it allows the drug to selectively suppress the rapid errant rhythm without paralyzing the normal slower rhythm. That is a truly smart targeting system.
It is.
Let's break down the 3 subclasses, starting with subclass IA. These produce a moderate sodium block, but they also have the secondary action of increasing the action potential duration and the effective refractory period.
The anchor drug here is quinidine. It's a really complex drug because it has multiple personalities, so to speak.
Now, sorry.
While it's primarily a sodium channel blocker, it also blocks potassium channels, which is what causes that APD prolongation. On top of that, it has significant anticholinergic effects and even some alpha-adrenergic blocking activity. This mix of mechanisms makes it effective against many arrhythmias, but also incredibly prone to side effects.
And the major theme we highlighted earlier returns immediately here. The major caveat of proarrhythmia.
Quinidine is notorious for it. Because it prolongs the QT interval, again, that's our marker for delayed repolarization, it significantly increases the patient's vulnerability to developing torsades de pointe. This is a life-threatening risk that clinicians have to weigh very heavily.
And the other side effects are unusual.
They are bizarre. We see synchoism, which is a cluster of symptoms, including tinnitus, ringing in the ears, visual disturbances, and hearing loss. Couple that with severe GI set and hypotension from that alpha blockade, and its broad-spectrum action makes it a very difficult drug for patients to tolerate chronically.
So, highly effective, but also high risk and a high burden of side effects. Next in this class, we have procainamide.
Procainamide is electrophysiologically similar in its effect. It slows conduction and prolongs the APD, making it effective for both supraventricular and ventricular arrhythmias. A key technical point you need to know about is its metabolism. It produces an active metabolite called N-acetylprocainamide, or NAPA.
And why is that NAPA metabolite important?
Because NAPA itself actually possesses class 3 activity. It blocks potassium channels. So the drug is technically a mix of class IA and class 3 activity once it's in the body. This dual mechanism extends its effectiveness, but it also contributes to its toxicity profile, particularly its tendency to cause QT prolongation.
Speaking of toxicity, the adverse effects of procainamide are unique, almost immunological.
They are. Long-term high-dose therapy can induce a syndrome called drug-induced lupus erythematosus, or SLE.
Like the autoimmune disease.
It presents very similarly to natural lupus arthritis, skin rashes, fever, fluid buildup around the heart or lungs. It can also cause severe blood disorders like agranulocytosis. The risk of SLE really limits its use primarily to acute IV termination of arrhythmias rather than chronic management.
It's truly shocking that treating an electrical problem can trigger a systemic autoimmune response. Rounding out IA, we have disopyramide.
Disopyramide is less commonly used today, but it's notable for its very strong anticholinergic activity. So that means severe dry mouth, blurred vision, and clinically relevant urinary retention. More importantly, it has strong negative inotropic activity.
Meaning it depresses the heart's pumping strength.
Exactly. For this reason, it is generally avoided in patients who already have congestive heart failure.
Okay, moving on to subclass IB. Here, the mechanism shifts a bit. These drugs block channels that are in the inactivated state, meaning they're great at targeting injured tissue. They have little effect on phase 0 and, unlike IA, they generally shorten the APD and ERP.
This is the realm of lidocaine, or lignocaine. It's most famous as a local anesthetic, but its cardiac application is highly specific based on that mechanism.
The blocking of inactivated sodium channels, why is that so critical?
It gives lidocaine its exquisite selectivity. When heart tissue is ischemic, lacking oxygen after a heart attack, those cells become partially depolarized, and their sodium channels spend a lot more time in the inactive state.
So that's the state lidocaine prefers to bind to.
Precisely. It selectively targets these depolarized or injured fibers, blocking the ectopic pacemaker activity that's originating from the damaged area, while having almost no effect on the normally polarized healthy cells nearby.
So it's the ideal choice for suppressing those immediate, dangerous ectopic ventricular beats that can erupt right after an MI. It's like a surgical strike.
It's exactly that. It's rapid, effective, and selective for ventricular arrhythmias like VES and VT. The main downside is pharmacokinetics. It is rapidly metabolized by the liver, so it requires a constant 5E infusion to maintain therapeutic levels.
And its toxicity.
It's almost entirely dose-related neurological effects. Dizziness, drowsiness, paresthesias, sometimes confusion, or even seizures. These CNS effects actually act as a helpful warning sign that you're approaching an overdose.
And for chronic management, our sources list an oral alternative, mexiletine.
Right. Mexiletine is essentially the oral analog of lidocaine. It allows patients to maintain that selective class IB action long-term for chronic suppression of ventricular arrhythmias without needing to be hooked up to an IV drip.
Okay, let's address the big guns. Subclass IC. These produce a marked sodium block. They slow conduction dramatically, and they carry the highest risk profile for proarrhythmia.
IC drugs are the most potent sodium channel blockers we have. They exhibit a recovery time that often exceeds 10 seconds. They lock the channel down for a very long period.
What does that do to the heart's electricity?
It severely slows conduction throughout the atria, the ventricles, and his Purkinje system. This often results in a marked widening of the QRS complex on the ECG. This profound effect is what makes them so effective, but also so dangerous.
The prototype here is flecainide, and we have to discuss the cardiac arrhythmia suppression trial, or KCAST, which completely changed the entire field of cardiology.
The KINASE trial is perhaps the single most humbling piece of research in the history of antiarrhythmic therapy. Flecainide and its analog, encainide, are incredibly effective at suppressing premature ventricular contractions, PVCs, and at restoring sinus rhythm in patients with AF. The study aimed to prove that suppressing these PVCs after a heart attack would improve survival.
It seems logical. Get rid of the bad beats, save lives.
It seemed logical, but the results were the exact opposite of what was intended.
What happened?
They were catastrophic. The trial was prematurely terminated because the researchers found that patients who took flecainide or encainide experienced a statistically significant increase in mortality and sudden cardiac death compared to the patients who were taking a placebo.
Wow.
The drug was highly effective at achieving its electrophysiological goal. It got rid of the ectopic beats, but it actually increased the risk of the patient suddenly dying from more sustained fatal arrhythmia.
That is a profound finding. A drug designed to save lives ended up accelerating death in a high-risk population. What was the mechanism behind that failure?
The leading hypothesis is that in structurally damaged hearts, like post-MI, the profound conduction slowing caused by the class IC drugs actually exacerbated the conditions necessary for functional reentry, turning what were relatively benign rhythms into sustained, fatal ventricular tachycardia.
So what does this mean for the current use of these drugs?
It means the use of class IC drugs is now severely restricted. They are absolutely contraindicated in patients with structural heart disease, ischemia, or a history of VT or VF. Their use is reserved almost entirely for patients with symptomatic PSVT or AF who have structurally normal hearts.
It's the ultimate caution against simply treating the ECG rather than treating the whole patient.
Exactly.
Finally, in this class, propafenone.
Propafenone blocks sodium channels, but it uniquely possesses weak beta-adrenergic blocking properties as well, which technically makes it a mixed class 1 and class 2 agent. This dual action can be very useful for maintaining sinus rhythm in AF. But like phenylnide, it must be used very cautiously in patients with severe structural disease due to that potential for profound conduction slowing.
We transition now from the ion channels that govern impulse speed and duration to the external control system, the autonomic nervous system, with class 2 anti-adrenergic agents or beta blockers.
This is where we introduce the calming effect. Propranolol is historically the most studied and commonly selected beta blocker for arrhythmias, though others like metoprolol are also very widely used. The key mechanism is dampening the sympathetic storm.
And how does that help control rhythm?
By blocking beta receptors, these drugs suppress the SA node's automaticity, and they decrease the slope of phase 4 depolarization, especially when that firing is being enhanced by high levels of adrenaline. They essentially slow the heart rate down.
So they slow the primary pacemaker.
Right, and crucially, they dramatically prolong the effective refractory period of the AV node.
So they are essential for two main purposes: suppressing arrhythmias, triggered by things like exercise or stress, and acting as traffic control for the AV node.
Exactly. They are the cornerstone for controlling the ventricular rate in chaotic rhythms like AF or atrial flutter. They ensure that even if the atria are firing at 400 beats per minute, only a manageable fraction gets through to the ventricles. They also, importantly, reduce mortality post-MI, which places them in a separate, much safer category than many of the Class A agents.
And what about the specific agent for rapid emergency rate control, esmolol?
Esmolol is a clinical favorite in the ICU or the operating room because it's a rapid onset, ultra-short-acting IV beta blocker. Its half-life is measured in minutes, not hours, which makes it highly titratable.
So you have more control.
You have complete control. If a patient becomes hypotensive or suffers heart failure, you just stop the infusion and the effects vanish very quickly. This makes it invaluable for urgent ventricular rate control in unstable patients, particularly those undergoing surgery or in critical care.
Now we address class 3, potassium channel blockers. These are the drugs that dramatically widen the action potential. And the most powerful, most complex, and arguably the most notorious of these is amiodarone.
Amiodarone it's in a class by itself, really. It's categorized as class 3 because its primary effect is prolonging repolarization by blocking potassium channels. However, as our source material notes, it truly possesses properties of all 4 classes.
All 4.
It blocks potassium channels, class 3, sodium channels, class 1, calcium channels, class 4. And it has non-competitive beta-adrenergic blocking properties, class 2. It is the true broad-spectrum heavyweight of antiarrhythmics.
Its efficacy is unmatched, but that strength seems directly tied to its major pharmacological complexity. Tell us about its kinetics.
It is highly lipophilic and contains high levels of iodine. Its mechanism prolonging the APD and ERP is excellent at abolishing reentry circuits. However, its half-life is astonishingly long. We're talking 3 to 8 weeks.
Weeks, not hours.
Weeks. It accumulates extensively in high concentrations in nearly all body tissues: fat, lungs, liver, skin, and the cornea of the eye.
3 to 8 weeks. That means if a patient stops taking it, the clinical effects and the potential side effects are going to persist for months. What are the severe consequences of this extensive accumulation?
This is where the caution becomes critical. The most serious and dose-limiting adverse effect is pulmonary alveolitis and fibrosis. This is scarring of the lung tissue that is progressive, often irreversible, and can be fatal.
So you have to monitor lung function constantly.
Constantly. Other major side effects include corneal microdeposits, which can cause patients to see halos or have blurred vision. There's also profound photosensitization, leading to severe sunburn, even with brief sun exposure. And because of its iodine content, it frequently causes thyroid dysfunction, either hypothyroidism or hyperthyroidism.
It sounds like taking amiodarone is a major life commitment. It changes everything from their need for sunscreen to their thyroid status. If it has such a profound and potentially lethal toxicity profile, why is it still considered the gold standard in so many situations?
Because of its unmatched efficacy. Its broad-spectrum action makes it effective against almost every type of arrhythmia, from PSVT and AF to life-threatening VT and VF. In the face of refractory, life-threatening arrhythmias, its proven ability to maintain rhythm often outweighs the chronic toxicity risks, especially when other drugs have failed. It buys time, and it saves lives.
Moving to the attempt to create a safer amiodarone.
Dronedarone was specifically synthesized as a non-iodinated congener of amiodarone. It was an attempt to retain the multi-channel blocking benefits while eliminating the major toxicities like the thyroid issues and reducing that accumulation risk.
And did it work?
In terms of toxicology, yes, it succeeded. It has a much shorter half-life of about 24 hours. But the clinical trials present an undeniable obstacle to its widespread use.
What did they find?
The Palace and Athena trials yielded a crucial safety nugget that you have to know. While it's less toxic than amiodarone, it proved to be dangerous in specific high-risk populations. It is now strictly contraindicated in patients with permanent atrial fibrillation or severe heart failure.
Why? What was the risk?
Using dronedarone in these patients was shown to actually increase the risk of death, stroke, and heart failure hospitalization.
This highlights the terrifying complexity of cardiac physiology. Removing one problematic chemical feature, the iodine, can inadvertently introduce new, fatal interactions in compromised hearts.
It's a perfect example of why the choice remains so empirical. Finally, in Class 3, we have sotalol. Sotalol is a unique combination product. It possesses potent, non-selective Class 3 potassium channel blocking properties and Class 2 beta-adrenergic blocking properties. It's effective for maintaining sinus rhythm in recurrent AFAL and for preventing symptomatic VT.
But it carries the same risk as the other QT prolonging drugs.
It does. It mirrors quinidine and other Class 3 agents. Because of its QT prolonging effect, it carries a significant risk of inducing torsades de pointe.
We turn now to Class 4, calcium channel blockers. These specialize in the slow, traffic-controlling currents of the heart's central hubs.
Verapamil and diltiazem are the non-dihydropyridine calcium channel blockers we focus on here. They block the calcium-mediated slow inward current.
And as you said, the SA and AV nodes rely heavily on these calcium currents for their function,
which makes these drugs powerful nodal depressants. They significantly slow SA node automaticity and dramatically slow AV nodal conduction and refractoriness. If the AV node is the gatekeeper, these drugs slam on the brakes, providing vital protection to the ventricles below.
So what are their key clinical roles?
Primarily, they are used for two things: acutely terminating and preventing the recurrence of PSVT, and controlling the ventricular rate in chaotic atrial rhythms like AF or AFL. We use them to make sure the ventricles are not activated too rapidly by the chaos in the atria.
Specifically, how is verapamil used to terminate PSVT?
IV verapamil is often a first-line therapy for PSVT termination. It works very rapidly, usually within 2 to 3 minutes, by blocking the AV nodal reentry circuit that causes the PSVT.
But there's a major caution here.
A huge caution. Because they are potent vasodilators and they depress contractility, they should not be used in patients with pre-existing hypotension or congestive heart failure. They can cause cardiovascular collapse in those patients.
Why are they so dangerous in CHF? Is it purely the negative inotropic effect?
Yes. In a patient whose heart is already struggling to pump, introducing a drug that further weakens that contractility and lowers their systemic blood pressure at the same time is a recipe for disaster. This is a crucial line that clinicians cannot cross.
Finally, we address the specialized agents that stand outside the von Williams classification, starting with the fastest chemical reset button in medicine, adenosine.
Adenosine is an ultra-short-acting endogenous purine nucleoside. And when we say ultra-short, we mean it. Its half-life is less than 10 seconds.
10 seconds.
It's rapidly taken up and metabolized by blood cells. It's gone almost as soon as you inject it.
Given that short duration, it must have an immediate and incredibly powerful effect to be clinically useful.
It does. It works by activating the A1 receptors on cardiac tissue. This activation indirectly increases the potassium current, which causes immediate hyperpolarization and dramatically depresses AV node conduction. It essentially causes a brief therapeutic second or third degree heart block in the AV node,
which stops the reentry circuit cold.
Exactly. It achieves rapid termination of PSVT in over 90% of cases, making it the primary diagnostic and therapeutic tool for that specific rhythm.
And there's a crucial detail to remember about what can block its effect.
Yes, its effect is completely blocked by competitive antagonists like theophylline, which is used in asthma, and critically, caffeine. If a patient has consumed large amounts of coffee, the initial dose of adenosine might be completely ineffective, requiring much higher doses to overcome that block.
We've navigated the chemical and electrical landscape. And the overall impression is one of immense power, coupled with immense risk. We need to circle back to the core ethical and clinical dilemma in this field, what our sources call the paradox of proarrhythmia.
This is the shadow that defines all of antiarrhythmic therapy. We're discussing drugs specifically designed to stop dangerous electrical rhythms, yet their very mechanism of action altering the flow of ions means they can, and frequently do, cause new, equally or sometimes more dangerous arrhythmias, or they can significantly worsen existing ones.
It's a knife edge. Can you give us a few concrete examples of how a therapeutic action becomes a proarrhythmic one?
The most common mechanism is that QT prolongation we've been talking about. Any drug that excessively prolongs the QT interval class IA agents like quinidine or class 3 agents like sotalol creates the necessary electrical vulnerability, those EADs, that can degenerate into torsades de pointe.
And the QCAST trial.
And the KST trial is the other classic example. Class IC drugs like flecainide can turn a low-risk intermittent ventricular beat into a sustained fatal ventricular tachycardia, especially in scarred or ischemic hearts.
So the line between the therapeutic window and a toxic catastrophe is razor thin. This brings us to the challenge of determining choice in use. If the stakes are this high, how do clinicians confidently select the right agent for the right patient?
It is an extremely challenging and largely empirical task. The choice depends on a precise, multi-layered evaluation. The exact ECG diagnosis, is it AF, PSVT, or VT? The likely underlying electrophysiological mechanism, is it automaticity or reentry? The specific drug's pharmacokinetics, and most critically, the patient's underlying structural heart disease status.
We saw how devastating structural heart disease can be for Class IC drugs. Does the overall safety margin for this entire class of medications tend to be narrow?
Absolutely. The majority of antiarrhythmic drugs have a very narrow margin of safety. The risk of proarrhythmia must be constantly justified by the severity of the symptoms being treated. The overriding goal is not just to normalize the ECG, but to truly improve patient outcomes.
And what does our source material conclude about the long-term benefit of using these powerful drugs? This seems to be the most critical point.
This is perhaps the most sobering nugget of all. The consensus, based on decades of clinical trials, is that chronic antiarrhythmic use, especially with classes 1 and 3, may afford no survival benefit, and, in fact, can often increase the risk of sudden cardiac death over the long term.
With a few exceptions.
With a few key exceptions, like propranolol, post-MI, and amiodarone in specific high-risk contexts. But for many, we may successfully fix the rhythm, but we often fail to improve long-term mortality.
That reframes the entire mission. Sometimes rate control is the wiser and safer choice than aggressively seeking a perfect sinus rhythm. Let's finish with a clinical summary for you, the listener, tying specific clinical scenarios to the strategic drug choices we've discussed.
For acute termination PSVT, speed and specificity are key. The first-line choices are IV adenosine or the AV nodal blockers verapamil or diltiazem. They shut down the AV node quickly and effectively.
If the patient is in AF or AFL and the priority is protecting the ventricles from the chaos, what we call ventricular rate control, what are the immediate go-tos?
There we use IV esmolol if it's urgent, verapamil, diltiazem, or oral beta blockers. The goal is simply slowing the AV node.
And for long-term maintenance or prevention of the absolute worst-case scenario, ventricular fibrillation.
While VF itself is terminated by defibrillation, the maintenance therapy to prevent it from recurring often relies on the most potent agents like amiodarone or sotalol, or, more commonly today, a combination of drug therapy and an implantable cardioverter defibrillator, an ICD, to handle any future catastrophic events.
The journey through these four classes reveals a remarkable chemical precision aimed at fixing these electrical faults. It seems you need to know exactly which ion channel is malfunctioning to select the right tool for the job.
We've concluded our deep dive into the heart's electrical system. We've mapped the mechanisms of chaos automaticity, after depolarizations and reentry, and we've matched them to the four classes of drugs designed to modulate the key ion channels: sodium, beta receptors, potassium, and calcium. The entire system depends on a chemical balance so fine that the difference between a cure and proarrhythmia is often just a single milligram of a drug.
It's incredible that we can target potassium efflux in phase 3, or design a drug like lidocaine to selectively target only the sodium channels in ischemic tissue. We seem to understand the mechanism down to the molecular architecture.
Yet, despite this comprehensive molecular-level knowledge, our source material concludes with a powerful, almost humbling statement. The practical guide to the choice and use of antiarrhythmic drugs is still largely empirical.
Meaning, based on experience and observation, not just theory.
Exactly. Clinical efficacy and safety are determined more by the outcome of broad clinical trials and decades of experience than by a perfect predictable model based on a single patient's specific electrophysiology.
So what does this all mean for you, the listener?
This raises a really important question for you to consider. In a world of personalized medicine where we can genetically map complex diseases, why does the simple electrical system of the human heart, governed by only a few key ion channels, remain one of medicine's most stubbornly complex and unpredictable frontiers? Why, after decades of research, is treating cardiac rhythms still a clinical challenge defined by trial, error, and immense caution?
That's the deepest dive of all.
It is.
A challenging and important question to end on. Thank you for guiding us through this essential, life-saving, and incredibly complex field.
Always a pleasure.